And a very good morning. Welcome to this webinar hosted by the Pan American Health Organization on the initiative for the elimination of mother-to-child transmission of HIV, syphilis, hepatitis B, and Chagas disease. Thank you very much for making yourselves available for this event. Today, we are going to discuss some points regarding the ETMI Plus Initiative. We're going to have reports and updates and progress reports on the elimination of vertical transmission, and also the official launching of a course on accelerating the elimination of congenital syphilis. Just a reminder that we do have simultaneous interpretation available today in English, Spanish, Portuguese, and French. So you can select the language at the bottom of your Zoom screen after you click the interpretation icon.
Welcome you all for this webinar today. Just a quick reminder also to in English regarding the interpretation. We have interpretation today during the webinar in the 4 languages: English, Spanish, Portuguese, and French. So feel free to select the most appropriate language using the Zoom features down below. And moving on with our agenda today, I would like to start with our opening sessions and welcoming remarks. And I would like to invite Dr. Massimo Guidinelli. Dr. Guidinelli is the Director of the Department of Communicable Disease Prevention, Control, and Elimination at the Regional Office, the Pan American Health Organization. Massimo, please, you have the floor.
Sí, muchas gracias, Leandro.
Thank you very much, Leandro, and a very good morning to everyone who is here with us at today's session. It is a pleasure to again see many colleagues with whom we have shared part of this journey to build and strengthen this experience of the ETMI Plus initiative. I would like to talk about this decade of achievements and successes in this very strong and positive regional initiative. I would say that perhaps the biggest success of the ETMI Plus initiative, and we'll hear more details about this later, but its biggest success has been its capacity to integrate and bring together various public health programs on a single platform. And in this way, to not only favor integration, but also the achievements and all of the positive outcomes that we are celebrating today. I am talking about a fundamental program that has a priority presence in all of the countries, and that is the maternal and child health program. And specifically the aspect related to prenatal health. This is the platform on which inputs from the HIV, immunization, and other programs, and also the vector control programs have been engaged, because now we're addressing Chagas disease. And this is how we have been able to achieve so many things, such as elimination. But we've also achieved another very important and fundamental objective. We have improved the quality of maternal and child health service delivery programs and antenatal care. Today, with the launching of this initiative, we have other countries. Cuba started in 2015 as the first country, and now we have 4 more countries that are moving towards certification of elimination this year or in 2024. Also, at the technical and theoretical level, we have up to 16 countries that have technically achieved the elimination of hepatitis B. So I believe that we still have a lot of work to be done. And this is an opportunity to remind everyone and thank those who are directly involved and acknowledge the central role played by the Regional Validation Committee, accompanying all of these steps and achievements over these 10 years. I recall the meeting held a few weeks ago in Washington, D.C., and ultimately the committee went back to having an in-person, face-to-face meeting at PAHO headquarters. As is often the case, this is now more in a central position with a very innovative approach to this subject matter. Today, we also share a very deep concern. The issue of ETMI Plus continues to be a glass that we might see as very full, but which still is partially empty. And that is where our concern lies. Today's biggest concerns have to do with congenital syphilis. We all know how the pandemic set back so many public health programs, and ETMI Plus, and certainly some of its components suffered from the pandemic. One specific thing is congenital syphilis, and we have data that is quite worrisome. We see a decline in the rate of coverage of treatment for pregnant women, and it wasn't that great before the pandemic, but without a doubt, it has deteriorated during and since the pandemic. We have new cases of congenital syphilis that were reported in 2021. And quite frankly, this is unacceptable for a condition that has a host of preventive measures and with proper coverage should not occur. So we need to improve care and renew this approach to the syphilis and the problem of congenital syphilis. Just a note of caution. There are clear indications that congenital syphilis will not be eliminated when amongst the general population and when in the context of more impacted key populations, and even when the specific population of pregnant women. So whenever amongst these populations, the prevalence of syphilis is above a certain threshold, then the elimination of congenital syphilis, despite our multiple interventions, is a very elusive goal. So I welcome you all, but I did want to welcome this call to attention to redouble our efforts in fighting congenital syphilis. I also send congratulations to Susana and our colleagues from the CLAP, Rodolfo, and congratulations for the presentations that were the launching of the new course, which is going to include the state-of-the-art and clinical and preventive and diagnostic approaches in terms of handling syphilis infections in pregnant women. However, we should not lose sight of the fact that this needs to go hand in hand with other actions targeting the general population and perhaps in a more targeted way to populations in situations of vulnerability that have higher rates of prevalence and incidence and therefore transmission of syphilis. Thank you once again for your participation in today's webinar. And with a desire for the complete success of this initiative, I hand you back the floor. Leandro speaking now. Thank you, Massimo. I now invite Dr. Susana Cerulla, who is the director of the Latin American Center for Perinatology of the PAHO WHO. Dr. Cerua, you have the floor. Thank you very much, Leandro. Good morning, everyone. Can you hear me? You heard me before. I regret the fact that I could not be at a more suitable place to issue this welcome. I am not speaking only on my own behalf, but also the clap. But
Fitzgerald, que es el director de la
I'm
nueva
not speaking only on behalf of myself in the clap, but also on behalf of Dr. James Fitzgerald, the Director of Health Systems and Services. We believe, and now I see that we have passed the 200 mark in our participants, but the issue of syphilis and congenital syphilis is fundamentally an issue of quality of care. We now have a new director for PAHO, Dr. Jarbas Barbosa, who at his inaugural address stressed the importance of addressing issues that we face for decades and make examples of them for elimination. We have abundant evidence that this can be eliminated, and we have an indicator that shows that we have more than 95% of women who receive antenatal care. And we have the tools, we're familiar with the tests, the diagnostics and treatment, and we are capable of handling this. So why does this persist? One element is what Massimo just mentioned. We also need to look outside the pregnant population and neonates to look at the population that still has high rates of syphilis and beyond pregnant women. These are vulnerable people who do not get diagnosed, do not get a tested and treated. And we need to start there, but there is a specific challenge with pregnant women, and we continue to insist on this for some time. We have said that at the beginning of antenatal care, we should do test and penicillin treatment and at least eliminate congenital syphilis. So we need to screen these women. Often it's secondary syphilis, and generally it's secondary from her partner. So we are not able to review some components that go beyond the health sector, such as education of women, prevention, and as we just said, prevention outside of pregnancy. I'm focusing on this because I think that the issue of quality of care is very expensive at this point in time for PAHO. The pandemic has taught us that primary health care and community care, the first point of contact for this patient needs to be highly qualified in order to have good outcomes so that we can achieve the outcomes we desire. So I see the syphilis movement as a movement to have better quality of primary care in the community and care for a woman who goes to an antenatal checkup and should bring in her partner so that then we can have follow-up with skilled health workers. I think that the region of the Americas can accomplish this. The countries in our region have a high rate of antenatal care. We have very qualified staff. And so with the course being launched today, and I wish to thank our colleague, Gabriel Listovsky from the PAHO Virtual Campus, this should become a tool a very important tool in terms of advocacy, diagnosis, and treatment. So as the bloggers say, I'm going to follow this on the virtual sessions. Once this is over, please send it to your colleagues. You can find this on our website, and we'll be sending each and every one of you a recording of this meeting. Let people know that there is a course on the virtual campus of public health that is free of charge. Everyone who can should take the course and implement this tool in the settings in which you work. We want you to listen to us so that we can effectively implement high quality care for women, for their newborn children, and for the rest of the population. This is what we have been talking about. A woman who has syphilis and a newborn that has syphilis are the most vulnerable people that we need to care for, and we need to strengthen and improve care for them. Thank you very much. I wish you an excellent meeting, and I thank you all for being with us today. Thank you very much, Dr. Cerrulla. Now, continuing with our agenda, and to close out the welcoming segment of today's meeting, I invite Mr. Dean Chambliss to speak. He is the Sub-Regional Director of the PAHO WHO Caribbean Office. You have the floor, Dean.
Good morning, and thank you very much, MC. I hope that you're able to hear me and see me all right. I know there have been some challenges with the audio. I will try to go slow for the interpreters. First of all, I would like to acknowledge those who join us from member states, partners, and PAHO colleagues in several different locations today. Good morning to you all. In 2010, member states of the Americas committed to eliminating the transmission of HIV and syphilis from mother to child. In 2016, this commitment was expanded to include the elimination of mother-to-child transmission of hepatitis B and Chagas as a public health priority. This initiative, known as EMTCT+, was and remains a clear indication that the countries of the Americas prioritize the improvement of health outcomes for pregnant women and their children, as well as the elimination of key communicable diseases. The certification of EMTCT+ is the result of a harmonized approach with integration of the primary prevention and treatment for the 4 diseases into maternal and child health services, with strategic linkages with other services such as sexual and reproductive health, family planning, laboratory services, and surveillance at the primary care level. Achieving EMTCT+ certification is a significant marker of the quality of services provided by the maternal and child health services, and therefore, attaining and achieving validation of EMTCT+ is a tremendous accomplishment. Maintaining this status is equally important and requires sustained efforts to prevent new infections in infants, children, and adults. This is especially important since the COVID-19 pandemic brought unprecedented challenges to the Elimination Initiative, affecting the delivery of primary prevention and treatment services for pregnant women. To support countries in effectively attaining and maintaining the EMTCT elimination status, PAHO collaborated with the Center for Perinatology to develop the e-training course that will further enhance the capacities of all healthcare providers to provide timely and quality services to all syphilitic pregnant women, their partners, and exposed infants. This e-training would not have been effective without the support of the dedicated healthcare professionals from the Ministry of Health Jamaica that provided and contributed real-life experiences to the process from its inception. I applaud the strong commitment by national and regional leaders, advocates, and healthcare providers across the region as they keep this elimination initiative as a high priority. Member states have also committed to the elimination of HIV, sexually transmitted infections, and viral hepatitis as public health threats. I would like to recall that the elimination of mother-to-child transmission of HIV, syphilis, and Hep B is within the wider framework to ending HIV and STIs as a public health problem. Before closing, I wish to pledge PAHO's continued support to our member states as they work hard to ensure a generation free of HIV and congenital syphilis, and the elimination of other communicable diseases and conditions detailed in the elimination agenda as public health threats in the Americas. Thank you once again, and I wish you a very successful seminar. Over.
Thank you, Mr. Chambliss, and thank you all the other directors for the welcoming remarks. And moving on with our agenda, let's start with our first session. And well, just a quick reminder regarding the session today. And also for the objectives, I think that the opening session was already showed us the objectives of this session today, the webinar today. We are going to show and to present some updates regarding the progress on the elimination initiative, the EMTCT Plus Initiative, as well as some updates regarding some guidances and tools available for to support countries in the validation process. We are going to hear from countries' experiences. We have Brazil, Jamaica, and Peru that are going to share a quick experiences regarding the efforts towards the achievement of the MTCT of HIV and syphilis. And finally, we're going to have the official launch and demonstration of the course on congenital syphilis, already mentioned during the opening remarks. I'd like to also remind you that we have the Q&A session. So if you have questions, just put it here on the Q&A, and myself and my colleagues, we're going to work to answer on the Q&A session, but also at the end of this webinar, we have a time dedicated to Q&A, and some of the questions we can answer live during that moment as well. And we have also the chat. So if you could please introduce yourself and also engage on the conversations and on the discussions through the chat, we are most welcome as well. And again, remind me that you have the interpretations, so feel free to select the languages. And pasando entonces a la primera presentación.
Now going on to the first presentation under the updates. We are going to hear an update. I hope that you can see the screen. I am in charge of this presentation to give you an update of progress made. I am Leandro Sereno, an advisor in the Office of the Control of Communicable Diseases, and also part of the team coordinating the MTCT Plus Initiative. For this presentation, I wish to start with a general overview of implementation of the MTCT Plus Initiative. We are publishing a report on the first decade of the program, and as was mentioned by Massimo and Dean, it began in 2010. And also the elimination of congenital syphilis in the Americas, it started in the 1990s. We had a resolution and a real effort when the member states of PAHO took on a commitment for dual elimination of HIV and congenital syphilis. And Cuba in 2015 became the first country to certify elimination, followed by 7 other countries. Based on this experience with the elimination of vertical transmission of HIV and syphilis, the countries strengthened their commitment to this and this led to a desire to expand the initiative and to also include hepatitis B and Chagas disease. So I'd just like to remind you about the EMTCT Plus initiative when published in 2017, defined what elimination of each one of these diseases meant. And ultimately, it included indicators and impact indicators to be achieved in order to certify the elimination of this transmission, as well as program targets in terms of the coverage of the interventions that are being offered as part of the EMTCT Plus initiative. So coverage of antenatal care and hospital deliveries, of ART coverage, coverage of elimination of HBV, and others. So these are essentially the indicators that we use for monitoring progress towards elimination, and that's what we're including in today's report. In terms of the report, as we said, we have really, it's been more than 10 years. It's been since 2010, actually. And the EMTCT Plus Initiative report is one of the tools that we have within our toolbox prepared by PAHO to support the countries. We published a baseline report in 2010, and now we frequently publish progress reports. They were delayed somewhat with the pandemic, but we now have more than 10 years of implementation of the MTCT Plus initiative. Now we have a format for publications. We do not have a standard document like we had with previous reports for this year. We did this with more information notes available on the PAHO website. So this is available on each of the components of the MTCT Plus initiative. And we also have a table in which you can identify data by countries, what countries reported. And I am not going to go into those details in my presentation, but you can find it on the PAHO website. And we can also look at the data broken down by country. As a result of compiling data from various sources and the reporting instruments that countries are already using on GM-AIDS, spectrum estimates, PAHO, as well as data from literature and data that countries report directly to PAHO. And we always try to give the countries an opportunity to revise the data and to report on more updated data that may not have been reported officially.
Now, as Dr. Suzanne said, that when we speak of mother and child health in this platform, we're talking about 15 million pregnant women every year in the region of the Americas, more or less. And we've seen a consistently high level of prenatal care and also delivery care by qualified personnel. So this gives us an idea that women, their children, their families are in contact with and connected with healthcare systems and all of the necessary attendant preventive measures for mother-to-child transmission. Now, for HIV, testing coverage among pregnant women by subregion. In the screening, we see that in the first couple of years of implementation of the EMTCT Plus initiative in Latin America and the Caribbean, And over the last couple of years, we observe a certain stability, not so much progress. And then in recent years, in 2020, 2021, we see the effect of the pandemic, which did have an effect on many health care services, including mother and child health services. And so we still are waiting to see what the full impact that COVID has had on this will be. But even before the pandemic, we had observed an increase, yet there was still a room for us to increase this coverage. Now the curve is similar for treatment for pregnant women with HIV, reaching nearly 80% coverage with the rollout of the program, with a drop off over the last couple of years. Now we are at 78% in Latin America and the Caribbean. And we can compare that coverage of care of antiretroviral treatment and also the rate of HIV. We see a reduction in Latin America over the last couple of years, in which we are at 17%. That's an estimate. Now, since the beginning of the EMTCT Plus Initiative, 50,000 new cases of HIV in children were detected with the implementation of this initiative. Now, in the case of syphilis, we have a different scenario regarding the coverage of services. Latin America, for example, we have seen a lower level of screening for syphilis in pregnant women with year-to-year changes showing how inconsistent and unstable the data reported are, as well as coverage of treatment not being as stable. Now we go from high levels of coverage. We've almost reached the goal, but then the data reported to PAHO, we see a lower number of countries reporting information on syphilis. Now, as regards the number of congenital syphilis cases, we also observe an increase in the number of these cases and a reduction starting in 2018 and 2021. There's a 2.1 incidence rate of 1,000 live births. Now, if we aggregate this data, we see that this reduction throughout Latin America and the Caribbean and the Americas, including North America, this regional reduction was owing mostly to a reduction in Brazil, in blue, with a trend toward growth in 2018, but we still see a higher proportion of cases of congenital syphilis. But if we take all the countries together, we see an increase of the incidence of congenital syphilis going from 0.3 to 0.7 from 2016 to 2021. So we see an increase in the incidence of congenital syphilis in most countries of the region, followed by an increase of syphilis in pregnant women. That's the result. Here you have a breakdown of the data in the countries. There were fewer cases between 2015 and 2021, with the rises in Colombia, Argentina, Dominica, and El Salvador, considerable rises in these countries, just by way of example. And as Massimo said, and Dr. Saruya as well, we have to address syphilis in a broader way. Now, hepatitis. the coverage of vaccines in 2016, there was a high point of coverage, but then after that, we see a drop off of coverage. The third dose, as well as the 24-hour dose, both dropped. And this shows us that we still have much to do to strengthen and to resume the promotion or promoting greater coverage. This is a priority in our region. Now, as countries in the region were the first 30 years ago to adopt vaccines for HPV, the region, generally speaking, has already achieved the elimination of mother-to-child HPV with a lower than 0.4% of newborns having HPV. We have to do more work to show this achievement. Now, Chagas disease. We have limited data regarding the coverage on this service. We know that countries are updating their systems, their information systems, to include Chagas disease information. They are broadening their packages of services, seeking to eliminate mother-child transmission. But the truth is, we have very little data from countries regarding what's happening, and this shows us that progress is quite slow. So that's one of the challenges that we face. Now, the report also includes an analysis on the impact of COVID on these services. I'm not going to go into details. You can find that information in the report, which is on our webpage. But to sum up, most of the countries of the region reported some type of impact or disruption of services related to mother-child transmission, sexual and reproductive health, for HIV and Chagas disease. And to conclude my presentation, I would just like to comment a bit on challenges and next steps. So one considerable challenge that we face is to achieve political commitment to action in the health ministries and national governments, first and foremost, but to transform that commitment into action. And that can also help us overcome the second commitment, which is the verticality of these programs. There needs to be interprogrammatic coordination, immunization on HIV, Chagas disease, tied into sexual reproductive health, and countries that have shown to have made most progress with the initiative were the ones that had buy-in at the highest levels of leadership, with a stress on programs for mother and child health. They were the ones that had most effective programs. Now, information systems, about which we've already spoken, indicators need to be aligned, and hepatitis B and Chagas need to be included. That progress has been very slow, as I said. Now, scaling up access to services, screening, care, and treatment for countries. In order to do this, countries can make use of new technologies and algorithms, combined rapid tests, double tests, and the use of multiplex platforms to confirm infections. And so these new technologies should be considered in the effort to scale up access. Now, the control of HIV and syphilis in other populations, key populations, we've shown through different models, it's not possible to rein in the transmission of mother to child without also addressing other demographic groups. And lastly, I would also like to remind you that the program to eliminate mother-child transmission moves us toward the elimination of these diseases as a public health problem. And to that effect, the ETMI Plus Initiative is a part of a broader elimination agenda, which includes and combines different strategies for eliminating different diseases in order to identify synergies and to consolidate the coordination of efforts for elimination to step up the rate of elimination of these diseases. Thank you very much. Now, the next presentation, we can put off our questions until the end. I invite Sandra Jones, my colleague, who is a sub-regional advisor for the Caribbean on HIV, tuberculosis, and viral hepatitis. You have the floor.
Thank you very much. Good morning, everyone. Leandra, can you inform me if you're seeing my screen in the appropriate format?
Swap.
Wow. Okay. That's good?
Yes, it's good.
All right. So thank you, everyone. Thanks very much for joining this presentation today. I will take a couple minutes to go through the structure and the tools for EMTCT Plus. My focus will be more on the HIV, syphilis, and hepatitis B as Chagas, which you know is not endemic in most of the countries, but and also for which the methodology is currently under development. So why are we moving to triple elimination? Of course, you would agree with me that globally, the focus now is on triple elimination, as we see that all the HIV, syphilis, hepatitis B, they are all transmitted sexually, are often silent with long latency period, can cause significant maternal and child health morbidity and mortality. And of course, these are easily identified and can be treated to avoid perinatal transmission. When we talk about the triple elimination, we are referring to the transmission rate of the disease that is at a level that is below public health significance. That will not be of a problem or a concern. However, to reach this level, there are some key components that must be addressed. The primary intervention for these services, primary intervention for these services must be available. There must be clear linkages and integration with other services, STI, family planning, to actually name a few. And of course, early treatment of women and young girls, those are very critical. When we, in order to attain the elimination status, there are several components that are foundational and are required for a country to be validated. The validation is a process that attests that a country has successfully met the criteria for EMTCT. The programs and services must be of very high quality. Not only so should the program and services be accessible and available, but they should also be affordable. Laboratory services must include internal and external quality assurance. There is a need to ensure that if a test is positive, it's really positive and it's really negative. Proficiency testing is imperative, and the results must be documented. Surveillance and data is also another key foundational requirement. A country must demonstrate that there is the ability to capture and to capture, detect, and to monitor those cases that were identified. And of course, for human rights, which is a key component, countries also must demonstrate that the services are implemented within a manner that is consistent with human rights principles, gender equality, with supportive legal and policy framework. These are the criteria for the elimination of the mother-to-child transmission of HIV, syphilis, and hepatitis B, both the impact and the process indicators. I will not go through it in details, but most countries, I think, would have access to this information because it is also available on the website. Since the inception of the EMTCT of mother-to-child transmission of HIV and syphilis and the transition into EMTCT Plus, PAHO as a secretariat, which is shared with UNICEF, has developed a number of guiding documents to actually guide and support countries in strengthening their services and in the attainment of the validation status. The PAHO Secretariat was organized in 2011, and since then we have the Regional Validation Committee. And this Regional Validation Committee really was implemented in 2015 when Cuba was validated. Just very quickly, the structure for EMTCT validation, as I mentioned earlier, there's a secretariat for which PAHO and UNICEF shares a secretariat. And to initiate a country validation process, a formal request is sent from the Ministry of Health through the PAHO country office to the secretariat, which actually set in motion the process of validation. Also at the country level, a national validation committee is organized, and these things are always done maybe perhaps simultaneously. And the country validation committee is responsible for the collection of the data, the development of the report, and when the report is finalized and approved by and it's a multi-sectoral committee, the report is then forwarded to PAHO secretary, the EMTC secretariat through the country office. The Regional Validation Committee, which I mentioned was established earlier, this Regional Validation Committee is an independent committee whose responsibility is solely to actually review and to determine if the country has met the criteria for validation. If the RVC through the report determines that the country has met the criteria, then the RVC will plan a assessment, which is a combination of virtual and in-country assessment, and put together a team, a regional validation team that will support the implementation of the assessment. And this team can be comprised of members of the RVC, as well as experts comprising those 4 different foundational areas that I spoke about earlier, to actually form the team to actually complete the virtual and in-country assessment. Following the assessment, the regional validation team prepares a report. They submit the report to the regional validation committee. That in turn, if the report is approved and if the recommendation is that a country should be validated, then the RVC through the secretariat would submit a report to the Global Validation Advisory Committee, which would also review those reports. And if this committee determines that the country has indeed met the criteria based on those foundational areas that I mentioned earlier and the impact and programmatic targets, then a recommendation is made to the to WHO that that the country can be certified. I must note here that only WHO can certify a country. Just to recap, the Regional Validation Committee is independent of PAHO, and it assesses whether a country has achieved or maintained the validation status. And if the country has not meet the validation status, then they will not be forwarded to the global level. If the RVC does not recommend a candidate country for validation, the country will not progress for a global review. So as we transition from the elimination of HIV and syphilis to the inclusion of hepatitis B, the global guidance and the criteria and processes for validation was updated, and this document is on the website, and you can review the document from the website. It basically details the processes, as well as what should be, what are the expectations of the countries, as well as it includes special considerations for small countries with small populations and countries with a big migrant population. Since Cuba was the first country that was validated in 2014, some standardized tools were actually developed to support the assessment process at the country level. These tools were first used in Cuba, and they were updated following the Cuba's experience. Currently, these tools are also being updated to ensure that it supports fully the integration of hepatitis B. And these tools are available as a secretariat. These tools are made available to countries, so countries are aware of what are the key areas that they are expected to be evaluated on for the EMTCT of HIV, syphilis, and hepatitis B. The elimination of these diseases is not a one-time it's not a one-time process, but countries are expected that they will maintain the EMTCT status, the certification that was given by WHO. And so the Regional Validation Committee would review countries' maintenance based on the report that countries would submit. So while the country report for the initial validation process is more elaborate, this is a much it's a less intensive process, and it also uses a standardized format. And the same process is actually utilized, in which it is first reviewed by the RVC, and then secondly sent up to the global level for review, and initially and then by approval by the WHO, who issues a letter stating that the country continues to maintain the status. On the far right hand of my screen, I have the period in which countries are expected to send the reports. First, it was every 2 years, and now it is basically 4 years for small countries. And it's basically between 3 to 4 years for most countries and for most of the conditions. So over the years, PAHO, we have been providing support to countries for assessment and technical support to actually scale up and to advance to the EMTCT Plus validation. And throughout the process, we have identified some very key lessons, and which I am just going to share a few with you at this moment. First and foremost, we realize high political commitment is important, not only at the national level, but also at the sub-regional level, because collectively this helps to keep the EMTCT agenda on the EMTCT initiative on both agendas. The EMTCT validation process, it requires equitable access to quality maternal and child health services. This is clearly a major marker. It's a major marker for the quality of services provided by maternal and child health, and a major marker for the EMTCT validation. Also critically important is that the validation process, one of the lessons learned is that a country must have quality laboratory assurances, internal and external, in place. And of course, this must have proficiency testing, and it's being done at least once per year, especially for HIV and syphilis. And now for countries that are in the process of attaining hepatitis B, if this is not done for hepatitis B, then this is something that countries will need to consider. And of course, to have in place a surveillance system that will be able to capture and to adequately monitor the interventions and to accurately measure the outcomes and the impact over time. Critical to the EMTCT process, and we have seen this where for the HIV program may have been the program that would have initiated the EMTCT validation in a country, but very, very critical is the ownership by maternal and child health. All the services, the primary prevention and treatment services, is within this platform, and it reflects the integration, the adequate or effective integration of HIV and syphilis within the maternal and child health services. And since maintenance is very critical, it is imperative that the services are that the EMTCT strategy is owned by maternal and child health. Also, we have seen where the EMTCT has given visibility to other STIs. It has placed on national agendas as well as on the regional agenda the issue, the strengthening of services for syphilis. And so this is a critical area that we need to highlight, and we would want to see this actually strengthened. It's still lagging because we have seen where in the region there is greater reduction of EMTCT of HIV than syphilis, although syphilis diagnosis and treatment are much cheaper, but more emphasis continues to be placed on HIV. And of course, the EMTCT foments robust interprogrammatic collaboration and effective integration of the services. So these are just some of the key lessons learned, things that we have pulled out based on our technical support that we have provided to countries over the years. This is my last slide, so thank you very much for your kind participation and for participating in this session today. Thank you.
Thank you so much, Sandra, for your very good presentation, very clear, very detailed. Thank you so much. Bueno, seguimos entonces con nuestra agenda.
We will now go on with our agenda. We will now move on to the second segment of today's webinar, which is to hear about country experiences and good practices. We have planned to hear from Brazil, Jamaica, and Peru. And we will start with the presentation by Dr. Angelica Miranda, who is the coordinator of surveillance of sexually transmitted diseases at the Ministry of Health of Brazil. Dr. Angelica is going to present to us of the very successful experience of Brazil as part of a new approach to move forward with the elimination, and that is sub-national validation, application of the tools and methodologies that Sandra just told us about, applied by the Ministry of Health to validate municipalities, cities, and states in Brazil, acknowledge their achievements in elimination, and also inspire other municipalities and states to also seek certification of elimination. So, Dr. Angelica, you have the floor.
Thank you, Leandro. Can you see my screen? Yes, it's not in presentation mode, but we can see it. And now is it in presentation mode? Yes, it is. It's great. Thank you. I thank you for the opportunity to be here, for having invited me, Leandro and Pajo. It's a real pleasure for us to be able to share this Brazil's experience, and we're really excited as we adopt this new version in a country which, as you know, has more than 200 million inhabitants. So despite the fact that we have a universal public health care system, we do have many differences among regions. So how could we carry out a national certification process when we have big regional problems and from state to state still? So before I start to talk about our process, I think it would be worthwhile to show you information on our state. You can see that we are at different levels regarding HIV, syphilis, and hepatitis B. Our big problem continues to be the large number of cases of syphilis in pregnant women and congenital syphilis. We have brought down the number of cases of vertical transmission of HIV. We still have high levels of vertical transmission of syphilis. Now, this strikes us because in relation to HIV, we have nearly 95% of HIV positive pregnant women receiving antiretroviral treatment. I jumped this slide, but we also have a high level of pregnant women with syphilis during pregnancy. Now, we plan to, in 2023, include this. We have 73% of vaccine coverage for hepatitis B. That's beyond what is actually called for the elimination. Now, mindful of this data and the regional differences that we have in our country, we came up with this proposal based on the WHO guideline or guidebook and PAHOS, and we came up with our own national guide book. So this was in 2017 that we launched this first, and it only included the elimination of the vertical transmission of HIV. At that point in time, we achieved certification for the city of Curitiba in 2019. We also requested that São Paulo be certified and Guarama. We only work on the certification of cities over 100,000 inhabitants. I should underscore that São Paulo is a city that has nearly 12 million inhabitants, and it was able to be certified for the elimination of vertical transmission of HIV. In 2021, we produced a second version, iteration of our national handbook, including syphilis. Now, as we wanted to spur cities to review their data and the work they do at the municipal level, we brought together the WHO and PAHO guidebooks in making it possible for that certification be done by using a seal of best practices, of a good practice in the elimination of vertical transmission of HIV. Now, in those cities over 100,000 inhabitants, and we opened this up to states as well, for syphilis and HIV, or is just syphilis and HIV separately. Now, in addition to the elimination, we also it's also possible to have these different seals or medals, gold, silver, or bronze, as WHO does. Now, impact indicators to gauge progress as proposed by the WHO guidebook. We have the incidence for elimination as well as for syphilis and HIV, and we have those impact indicators as well in cities regarding the three colors of seals, gold, bronze, and silver. Now, as far as impact in the WHO guidebook refers to the incidence for HIV and syphilis. Now, as our level of incidence is low in Brazil, then we modified this regarding the incidence rate. The use of seals is based on the idea that WHO calls for the use of these seals for those countries with a high prevalence of HIV or syphilis. That's not our case with HIV, but there is a high rate of syphilis incidence. That's why we are using those seals. Now, the process indicators, we follow the WHO and PAHO standards with a minimum coverage of 4 prenatal visits, consultations. All the other criteria are the same ones used in the regional national guidebooks. Now, this process, our process of certification, I think it bears mentioning that we follow the same process. It's interesting that I speak after Sandra spoke, because we condense the data to ascertain what the rate of that the city or the state have. Then we reach out to those states to find out which cities within that state could request, that is, that meetings that be held between the state and the city to see if the cities could apply for the certification process, if they are eligible. Now, once that application is submitted, then a report is produced of all the data, of all of the process indicators following the 4 main points, which are in the WHO and PAHO guides, especially or including the human rights aspect. So the city invites or sends that report to the state. The state reviews it and sends it to the Ministry of Health. The Ministry of Health then convenes a national validation team, which are researchers, managers, healthcare professionals that are involved in this process. It just cannot be from the same state where that certification is being requested. So one state visits another, and that's very important, because this encourages the state that's going to be validating other states to take stock of its own situation, and then also to proceed with its own request for certification of the state or of its cities. Now, a report then is produced by that team. It's sent to the health ministry, which in turn convenes a national validation group, which are the 3 levels of government: federal, state, and city. They all send in representatives to UNAIDS, UNICEF, PAHO, the nursing council, civil society is also involved, and a final assessment is conducted for the purpose of validating the certification of that city. This process, truth be told, goes far beyond just offering a certification seal. It calls for reviewing the work processes of that city to see where the shortcomings are, that the city is where the city is coming up short, keeping it from actually eliminating vertical transmission of HIV or syphilis. This is the result of our 2022 process. 43 different cities were certified, and one of our concerns, and I know this is PAHO's concern as well, if we were to come up with a single certification just for syphilis or HIV, then our concern is that syphilis would be left behind. Now, our process here has shown us that syphilis was not left behind, though it's not quite as good as HIV. And so those cities that were certified for the elimination of HIV transmission, and then only one was certified for syphilis. Then there was one that received a double certification for syphilis. Silver went to 10, and 3 for syphilis, and the bronze, there were 4 cities that requested that for syphilis. Now, what struck us in this process is the breakdown in our country between the North and the South, the division. This is the division that we acknowledge that there is this regional diversity, and our process in 2023 seeks to increasingly spur the northeastern region of the country to take part in this process. Those cities that received the certificate of elimination received a plaque. And then the ones that got seals just got a certificate. So we have the problem that many cities wanted to get the gold seal. The gold seal is very important to them. And so what was our idea here? We created the diamond seal for certification purposes. So in addition to the plaque for elimination, they received the diamond seal to set it apart from the other gold, silver, bronze, which are best practices certificates as they move toward elimination. In 2022, we held a large event in which cities were the key players taking part, or they came to Brasilia to receive their certificate, and a video was created that's on YouTube to talk about the experiences of healthcare professionals, of the administrators, and of pregnant women who took part in this process. I would invite you to download this. There's a version of it in Spanish and English, at least in the subtitles. Now, for elimination, there was a city that received dual elimination. So it really does, this goes to show that it is an effective approach to work with cities to get them to reduce or eliminate vertical transmission of both HIV and syphilis. Now, we're going to include the discussion of hepatitis B and Chagas disease in the Pact for Elimination of MTCT, which was launched recently. This was a tripartite meeting involving the federal government, states, and cities that came together to create this pact to focus on the elimination of vertical transmission. So this criterion was included in the PAHO document, and here are our objectives. Just to give you an overview, those cities, to encourage them to apply by June 30th for certification. We received 111 applications from cities in Brazil of over 100,000 inhabitants that requested some type of certification, including 2 states that requested not just their cities applied, but the states themselves applied. Now, the number of cities in the north and northeastern region of Brazil has risen. This goes to show that this has been a positive experience and that we are on the right track. And this is snowballing in a positive way, and hopefully we will eliminate these maladies throughout Brazil. Thank you.
Thank you very much, Angelica. This is a very interesting experience and something that we've also learned with Brazil from that experience, and as PAHO, is to replicate this in other countries. We see that other countries, not everyone has the vast territory as Brazil, and there are major differences, but still they're all subdivided into regions, subregions, health regions. So this is an approach that could be adapted and applied to other countries. We can adapt these tools and these methodologies of the PAHO WHO to support countries in this subnational approach. So thank you very much.
would like to hand over the moderation to Sandra Jones, my colleague from the Sub-Region Office for the Caribbean. Sandra, you have the floor.
Yes, thank you very much, Leandro, and for actually moderating the first half of this meeting. So, and thanks very much to Angelica for sharing the very innovative experience from Brazil. Very much, it is so interesting. At this time, I'd like to call on Dr. Alicia Rob Allen from Jamaica, and she will be sharing with us the Jamaica's experience as they regarding their progress and their challenges in eliminating congenital syphilis. Dr. Allen, you now have the floor, please. And thank you for agreeing to make the presentation.
Morning, everybody. Thank you for allowing Jamaica to do their presentation. Dr. Brand, or Program Development Officer, who has the key responsibility for HIV and syphilis for the Ministry of Health and Wellness, will be doing the presentation. I'm just going to try and fix the presentation quickly so that everybody can see it in slideshow.
Great. Good morning, everyone. Thanks, Dr. Rob. My name is Dr. Camila Brand. So I'm the Program Development Officer for the HIV program, as well as the PMTCT program for Jamaica at the Ministry of Health and Wellness. So today we will walk you through the road to EMTCT for syphilis for Jamaica. All right, so just an overview of what we'll be looking at today. We'll be looking at the prevention of mother-to-child transmission of HIV and syphilis, the PMTCT program, the PMTCT program's management, service delivery in terms of the protocols that govern the management of syphilis in the pregnant woman, as well as the congenital syphilis rate, and also our status of positives for the period of 2020 to 2022, and some of the challenges that we've had. So in terms of our PMTCT program, the Ministry of Health and Wellness has established a program in terms of sexual transmitted infections and prevention of mother-to-child transmission of HIV and syphilis program. So the services that contribute to the program, it's made up by different key members. So there's a maternal and child health unit, there's our national surveillance unit. We have our hospitals, which encompasses our obstetrics team and our pediatricians. We have our laboratory service, not only our national laboratory services, but also regionally at different parish level. And we have our health records department, and we also have pharmacy. And in terms of our protocols, these are established for the management of syphilis, which resides both in our STI clinical management manual as well as our PMTCT manual as well. So in terms of our PMTCT program management, so we look at it in terms of department and the key function that each area plays. So for our maternal and child health unit, they offer primary prevention services for screening pregnant women for HIV and syphilis. They manage the pregnancy for our antenatal and postnatal period. The treatment of syphilis and the management of HIV in conjunction with HIV treatment team. They also review the infant and the mother for up to 6 weeks post-delivery. So in terms of our hospital, for our obstetrics and our pediatric team, they look focus on the management of a high-risk pregnant mother in the antenatal period, where they also manage labor and delivery, where they review the lab and they manage accordingly based on whatever would have transpired during the pregnancy. There's also the referral of suspected cases of infants that are delivered from that would have been delivered for management. There are also the investigation of mothers who deliver stillbirths, as well as the pediatric department manages all infants that would have been referred to them based on suspicion or for further management or follow-up. In terms of our national surveillance unit, they collate and analyze and interpret the data for action on any reportable communicable disease that would have been reported, whether it may be from the parish level and then sent up to the national level. That would have been stipulated in the Public Health Act and under the surveillance and surveillance, that would have been under surveillance. So in terms of our lab services, so all our local labs provide confirmatory testing results for HIV and syphilis, and this is offered across the country. In terms of our health records department, this is where they're the principal repository for our data and information for all healthcare services that are offered to all patients that access the healthcare facility. And our pharmacy, they are there to ensure the availability of our ARVs, whether it may be for mom or HIV exposed, as well as our penicillin that we need to treat our syphilis cases and other medications that may be required for both our pregnant women or infants if they would have tested positive for HIV or syphilis. So in terms of our service delivery, the protocols that are governing the management of syphilis in the pregnant women. So in terms of our antenatal screen, this is what we use in terms of our screening protocol. That is a part of our protocols that we use for our antenatal mummies once they would have access care. So for syphilis, we offer treponemial, the SD Bioline syphilis test, and it depends on the route that we go. So if they're non-reactive, you assess their risk factors. You repeat the SD Bioline at 28 weeks, which would be the third trimester, which is part of our screening protocol. If they have risk factors, you repeat the SD Bioline within 4 weeks, and that would have been for our non-reactive mummies. For those who would have had a reactive SD Bioline with a trust less than 4 dilutions, this is documented with documented treatment. They would have had adequate BPG 2.4 million unit stat, and that would be what we would do for those. In terms of our reactive, who would have had a trust greater than 4 dilutions, then they would have gotten treated with the BPG 2.4 stat or weekly as per diagnosis. Depending though, if based on documentation of a treatment, if it was a case where it was noted that the case was inadequately treated, then we would treat with the 2.4 MU stat or weekly as per the diagnosis based on what would have been elicited from the history and also the assessment when seen by the physician. So in terms of our service delivery, in terms of our mothers with syphilis status at delivery, this is what is done as part of our protocols for all mothers with a syphilis status at delivery. So if they have a documented treatment with at least 1 BPG greater than 30 days before delivery, and a non-treponemial test remains reactive. For the infant, if the infant is symptomatic or asymptomatic and has a 4-fold or higher titer than the mother, the infant is hospitalized and treated with the crystalline penicillin and classified as a confirmed case, and then is then referred to our CI. So our CI would be our contact investigator, and then they would then go ahead and do their investigation as needed and so forth, and then provide an outcome of the case. And this would then be documented. In terms of our infant, that would have been asymptomatic and has a title lower than mom, they would be treated with the BPG, 50,000 units per kilogram IM stat, and they would still be referred to the CI. So all cases are referred to our contact investigators because they still have to do their necessary investigation and then provide an outcome of the case where this is documented. So in terms of the documented treatment, for those who have had documented treatment at least one BPG greater than 30 days before delivery, and they have a non-treponneal test, non-reactive, they would require no infant for the infant. However, they would still be referred, as I had mentioned. All cases are referred to our contact investigators for investigation, for a full investigation to be done. In the event where they have a documented treated first BPG less than 30 days or before delivery, or they would have received erythromycin treatment, if the infant is asymptomatic, they still get the BPG 50,000 units per birth weight, and they are classified as a suspected case, and they refer to the CI where they undergo their investigation. They would also do their titles and everything, and then provide an outcome of the case. So, so this is basically giving you an outline of basically what we do in terms of our mothers for syphilis status at delivery. So in terms of our congenital syphilis rates, so as you would have seen over the years, we would have maintained in terms of our CS rates less than 0.5, which would have been what the our impact indicator, except for 2018, where we had an increase. I know that the pandemic, as was mentioned before, it was a period where a lot of programs would have been affected. However, for Jamaica, throughout the pandemic for 2020, 2022, we ensured that we not only met, but we not only attained, but we also maintained our impact and our process indicators throughout the period of 2020, 2022 or in terms of our syphilis rates and all the other impact indicators and process indicators. So if we looked at the status of our positive rate for 2020 and 2022, so the number of cases that we had for 2020 was 3. So in terms of looking at them in terms of treatment for BPG less than 30 days, we had none. What we had was 3 of our cases were actually treated with erythromycin prior to documented previous allergies to penicillin. For 2021, we had 11 cases with 9 of them treated with erythromycin and 2 that were due to late presentation. They presented and they got treatment less than the 30 days that would have been recommended by the guidelines. And for 2022, we had 14 cases. And of the 14, 11 of them were treated with erythromycin because these were prior cases of patients who had been reinfected with syphilis and were previously treated, but they were allergic to penicillin. And in the previous instant, they were actually treated with erythromycin and they were retreated again with erythromycin. And then 3 that were treated with BPG less than 30 days. So with that said, what are some of the challenges that we face as a country? So there's divergence from the treatment protocols in the case, and with that, we continue to resensitize and to retrain the physicians that are in the field in terms of the assessment and management of syphilis. There's also, and with that, we also continue to update our protocols and our guidelines on a yearly basis to and this is disseminated to our clinicians in the field so that they're updated based on the guidelines in terms of the treatment for syphilis. There's late diagnosis and subsequent treatment. So a lot of these patients some of them would have been had a non-reactive title or non-reactive SD byline initially, and then upon presentation for delivery, it would present now where the SD byline, which is now done, repeated, it would have now show up to be positive, reactive, and hence subsequent them getting treatment, which is less than 30 days. We have a very nomadic population, so persons tend to move between parishes to parishes, and they may start a treatment in one parish, and then they may move and not complete the treatment, and then they may present at delivery with a reactive title. And when the contact investigators would have done their investigation and tracing, they would have realized that the patient was actually from a different parish and would have had a incomplete treatment or for their syphilis, and hence them being treated less than the 30 days. The issue with the penicillin allergies, and as such, for that, the implementation of desensitization protocol is pertinent, and that is something that we are addressing, and we are looking to implement that in a short order. There is continuous resensitization of staff in the protocols. As we say, we continue to train and resensitize to ensure that we continue to have all staff members aware of what the protocols are, not just a part of our PMTC program, but also in our STI clinics. Because as mentioned before, it's not only our pregnant mothers that are having syphilis, but also our general population, persons that are presenting to our STI clinics as well. So, and also the reconciliation of data. So that is something that we are undergoing and will continue to review and update our data as we go along to ensure that we are truly capturing the actual number of what is happening in terms of our syphilis cases within our country. And that's my presentation. Thank you.
Thank you very much. Thank you very much, Dr. Rob and Dr. Allen, for the presentation, for sharing with us the progress and the challenges for Jamaica. At this point in time, we will want to go directly into the presentation for Peru, and Dr. Carlos Benitez will also be presenting on the progress and the challenges in eliminating congenital syphilis. Dr. Benitez, I now turn over to you.
Muchísimas gracias, Sandra.
Thank you very much, Sandra. I want to thank the organizers, PAHO in Washington, for considering Peru in this important meeting to discuss congenital syphilis, in particular within the plans for elimination. I have a very brief presentation and will primarily focus on the progress, but above all on the challenges entailed in eliminating congenital syphilis in our country. In these graphs, you can see all of the strategic interventions that the Peruvian program has. It encompasses sexually transmitted infections, including syphilis, HIV, and viral hepatitis. Therefore, we have axes along which we work with the component of prevention first. For example, you can see that in terms of the prevention practice, we have a symptom-based approach, including ulcers related to syphilis, but also, since this is an experience for which we've had good results, the axis of screening, diagnosis, and monitoring is important. Here, I'd like to tell you how important it has been in Peru's program to have immunochromatographic tests, such as for HIV, syphilis, and also for hepatitis B and hepatitis C. But particularly for syphilis, I'd like to tell you that previously we used a different type of test. For example, the antiponemic tests, but now we are using the rapid tests. And in fact, we have been working on dual rapid tests for both HIV and syphilis. This has made it possible not only, in addition to the advantages of the rapid tests, to take them outside of the laboratory and outside of health establishments into community spaces and right into the native communities in the Amazon region of Peru, as well as in the Andes, and also to work on the elimination of HIV. So in Peru, we are using dual rapid tests for HIV and syphilis, which has made it possible to have significant strides vis-a-vis closing the screening gap in key populations, particularly amongst pregnant women. In terms of treatment, the treatment axis here, I'd just like to say that in Peru, the treatment for syphilis in pregnant women is penicillin, and if there is a penicillin allergy, then we always have to do the sensitivity test. This is the roadmap that the country laid out several years ago, looking towards elimination of HIV, syphilis, and in the specific case of Peru, hepatitis B. As you can see here in 2015, we prepared some important standardized documents to standardize surveillance. And we also, in 2016, approved a national plan for the elimination of a maternal to mother-to-child transmission. And then in 2017 to 2019, we've had implementation. Now we are in the stage of monitoring and evaluation of that plan. And next, I'm going to tell you the indicators that includes. This is essentially what Leandro was referring to in his presentation, the impact indicators both for HIV and for syphilis, and the process indicators in terms of coverage and screening, which is very high, above 95%, and also what we've been using in Peru in terms of Hep B indicators. We're looking at a prevalence of less than 0.1% amongst children 4 to 6 years of age, and in terms of process indicators, HB vaccination within 12 hours of birth. So what we've been doing over this time is to implement the plan and monitor it. And in this slide, we have a cutoff with what occurred with the pandemic. I think we're all aware that the pandemic marks a before and after in terms of everything related to health, particularly public health. And we observe the following in the cohort that we have 2015 to 2019 on the left, and the cohort of HIV and syphilis screening coverage 2020 to 2022, we see changes in terms of what I've been telling you in terms of double screening tests for HIV and syphilis. We see that in both graphs, there is a higher level of screening of HIV than for syphilis, despite the fact that we have dual tests. And we see that in sometimes there have been problems in the procurement and distribution of the dual tests, and we've just been able to, we've had more access to HIV testing. In addition, despite the fact that during the pandemic, obviously, there was a reduction in health services such as cancer and other screening, we have indicators in the case of HIV close to 91, 92% screening coverage. And for syphilis, 89 and then 86, which marks a significant drop since the pandemic. At any rate, we are far from the coverage rates required to have 95% elimination, but this is what we have, and also the impact we see from the pandemic in terms of syphilis screening. This data has to do with treatment coverage, specifically for syphilis. And the cases of congenital syphilis that we've had, which are documented based on the evaluation criteria. Here we see that there has been a slight reduction in the 2020 to 2022 period in terms of syphilis treatment from 88 to 85% coverage. There's also been an apparent reduction in the cases of congenital syphilis from 1,442 in the period ending 2019 and 944 in the later period. But we should not take this at face value, but really analyze it in terms of incidence rates. As we can see here, and this was compiled from 2000 to 2022, we see very clearly that around 2005, the rate was above 1 per 1,000 live births, and then it was going down until 2020 when it went down to 0.4. At one point previously, it had been 0.4. However, it then increased to 0.6, and this is what we believe might mark an inflection point from which there is an increase. All of this is based on what happened with the pandemic. Here, we're now updating this, and we established 4 lines of intervention that are mentioned here. And I'm going to explain to you the key strategies that have allowed us to continue to work on syphilis. In the line of intensifying actions for promotion and prevention, what I can tell you is that the procurement and implementation of rapid dual tests, HIV syphilis, has been important in terms of increasing screening coverage, and also a communication strategy specifically for pregnant women and their partners within the health services and in the community in order to encourage education on this. Next, under strengthening the capacity and quality of health services, we have worked very hard on simplifying the diagnostic algorithm for syphilis. We're starting with a dual rapid test, which has a component specifically for syphilis. And what we see in the algorithm is to work on these tests. We had to do training of laboratory staff, and we've had first, we did not have treponemal specific tests, and then we did, but this has made it possible to be more timely, particularly in terms of beginning treatment for pregnant women with syphilis. This goes hand in hand with the second thing mentioned here, which is strengthening of laboratories, primarily in terms of serological rotators. One of the problems has been following up with newborns that have been exposed, particularly for HIV, but also for syphilis. So we have a specific strategy to recover children who have been exposed. And this has brought with it the detection of more cases of children infected with HIV. With the last line of work, we have establishing mechanisms to improve the management of information and public health surveillance. So we've designed an application to register pregnant women and exposed children. So this is done in the Ministry of Health. And finally, I would just like to share this initiative with all of you. It is an experience that the country had regarding syphilis. It's at the initiative of PAHO and other allies and through USAID. And here, this is all mentioned here. There's a report on this that can be shared. But I just wanted to share with you some key aspects of this experience of modeling. This has been extremely useful, particularly in terms of validating information through 2019 and through 2020. You can see the scenarios and the projection through 2030. What are the interventions, not only what they are, but which are the most cost-effective interventions that allow us to achieve our goals by 2030? It is quite clear that if we continue to do the same thing until 2030, what we see above as constant coverage, then we will not reach our goal, which is the gray line. But if we continue to move forward with each of these interventions, for example, if we have the maximum package of interventions, then we are very we're much closer to this. So this tool has given us guidance, particularly in terms of which interventions have the greatest impact. And we see clinical treatment of symptomatic cases, contact tracing, and also the use of screening with key population. As I said at the beginning, it's not just an issue of congenital syphilis and to focus on the pregnant woman, but we also have to focus on their partners and also on key populations. One of the things that the modeling tells us is that despite the efforts that have been made and progress made in the country, it is important to understand that with these same interventions, major strides won't be made before 2030. And secondly, within these biomedical interventions, we need to look at primary and secondary syphilis, and we have to address high-risk groups, particularly men who have sex with men and with their female context, in order to try to reduce syphilis in these populations, and in this way to have a significant impact on reducing mother-to-child transmission of syphilis. So we have some very concrete things in terms of contact tracing, offering treatment to symptomatic cases, and enhancing the coverage of condoms and screening, and all of this modeling has been very important for us. And so within our next steps, I would like to point out the following. We are engaged in updating the technical standards and incorporating HTLV infection and Chagas disease in order to have the full ETMI Plus Initiative included. But not only that, we have another disease that I'm sure is common to many countries of the region, which is HTLV1 infection. This disease is part of a case finding effort we've done, and we see that it has which does impact breastfeeding. So what we're incorporating into the standard is to have screening during pregnancy for positive cases to make sure that we can use breast milk substitutes to prevent this, and we're going to continue to implement this in the coming years. Another message that we have that we need to focus our interventions on I think we need to work in local cases and municipalities. For Brazil, this is very important in order to document heterogeneous progress being made throughout the country. And we are also incorporating, and this is also based on the recommendations of the model, the strategy and notification, or rather contact tracing, not only for HIV, but also for syphilis and hepatitis B. And in turn, we are updating the standards for the detection of sexual transmission of syphilis to enhance coverage of symptomatic or treatment of symptomatic syphilis. So these next steps have a lot to do with the national experience and also with the recommendations that the modeling showed is recommended for Peru. Thank you very much for listening.
Thank you very much, Dr. Benitez, for your presentation. And I know we are a little bit running out of time. And so I think this is a perfect way that which we could go directly into the next section of the agenda, which looks at the launch of the e-training course, which was developed to support the acceleration and the elimination of congenital syphilis. This was, of course, a long process, given all the dynamics as it relates to diagnostic and treatment of syphilis. And we heard that from both Peru and Jamaica. I want to take this opportunity to publicly thank the Ministry of Health colleagues for their support and their participation in sharing their experiences that allowed for this course to be a success. So without further ado, I will turn over to my colleague from the Virtual Campus for Public Health, Gabrielle Listovsky, to actually make a presentation on the role of the Virtual Campus for Public Health in accelerating elimination. So over to you.
Muy buenos días, muchísimas gracias, un cordial saludo.
Good morning, and thank you very much. Warm greetings from the regional coordinators of the PAHO Virtual Campus in Public Health. I'm sending you greetings from the office in Panama. And congratulations for the launching of this course. I wish to congratulate everyone involved, the CDE department, particularly the area of Dr. Ruben Mayorga, Dr. Susan Zerun, who is responsible for the CLAP. And I also want to thank Rodolfo Gomez for all of the joint work that we have carried out to implement this project. I will just take 3 short minutes to share a general comment and then give you the floor. The Virtual Campus of Public Health of the Pan American Health Organization is our tool for technical cooperation and education. We work across all of the departments and technical units. At this point in time, the Virtual Campus of PAHO has more than 2.5 million users who are enrolled in more than 5 million courses. This means that each one of you who are now participate in the virtual campus, if you're not in a course now, certainly tomorrow, or who are now in a course, will visit another one in the next couple of days. So now we have the course, the Spanish version of the course that we're talking about. We have 325 people enrolled without having formally launched it yet and without having begun the discussion. And now we have 35 of you approved and about 80 people for the English version. And I think that we already have somebody approved for French. So we have colleagues listening to interpretation into French. You are invited to actively join the virtual campus. During this session, I have been posting direct access to this in the chat, but I just would like to say something. I'm going to share a 3-slide presentation. Let me know if you can hear it see it correctly rather. I imagine you do. And very quickly, I want to welcome you to the course. Here, for everyone who is asking us about it, you have the link to the virtual campus and public health. And on the top, you have the option to choose the language, Spanish, English, Portuguese, or French. Each one of you, if you already have an account in the virtual campus, you can use your username and password. But if it's the first time, we hope that you'll create your account. You'll have to put in some of your personal data. And this helps us to geo-reference throughout the Americas amongst our users and even throughout the world. People from more than 200 countries are visiting our campus, so you're all welcome to visit our website, and all you have to do is create a username and password like we do with our accounts everywhere. And then once you are enrolled, you choose self-learning courses. And in the list of self-learning courses here on the left, I put in 3 of them. These are also linked to today's topic. In the middle, you have the accelerating elimination of congenital syphilis. That's an English screenshot, but don't worry, if you want to look at it in Spanish, you will have no trouble finding it. And Rodolfo is now going to give you some more details about the course. This is the certificate of participation for everyone who meets the requirements. It's approximately 12 hours of work, including reading it, taking the test. Everyone who fulfills the requirements will be able to do a quality survey, which is very useful for us, and will receive a certificate similar to this with the signature of our director. Let me know if you have any questions. I'm having trouble logging in, these types of issues, technical issues, and the use of the virtual campus. You have a link there for the virtual campus help desk. And here we have some key recommendations. Use it on a regular basis. Enter it frequently. Also, discuss this with your colleagues like you're doing today in the chat. Uh, uh, Take it to your health center, discuss it with your colleagues, recommend it to colleagues who are not attending this webinar today. Also perform the activities. There are always multiple activities and options before and after the exams. And here we have a great variety of courses. This is a screenshot of all of the areas that we're working on. I know there are some that aren't even here. And so we would love to see you in the virtual campus in public health. We'll work on the course, and we hope that this afternoon we will have far more enrollees in this classroom. And Rodolfo, the floor is yours. Thank you very much, Gabriel. I am now going to share the presentation that I've prepared for today. And very briefly, I would just like to be respectful of the time, which is running out. I'm going to try to share with you the course that we've shared and made interprogrammatic and interoperable. So it's to share success stories in the region. We want to thank the countries that shared that, as well as some of the challenges. So amongst these challenges, we've been working on this for more than 100 years on treatment of syphilis, and we know that penicillin is the best amongst pregnant women. The only treatment that has been proven to be effective for preventing congenital syphilis during a pregnancy is penicillin. There is no other treatment that has been proven to be as effective as that. It's cheap, there is no bacterial resistance, and in a region that has more than 90% antenatal care, it's the only way. Why haven't we been able to eliminate this? What are the problems? So this course answers that question and tells us what the challenges are that we found, and we have not yet been able to eliminate congenital syphilis. When I say this, I want to invite you to think not so much of statistics, because 0.5 per 100,000 or 10,000 or whatever, it seems like a figure, but today I want to invite you to think about this woman and this child and this family. This family, which could prevent a disease that could cause death during pregnancy, could cause birth defects, and may have long-term consequences for the newborn, who may be marred for life.
So I'm trying to call people's attention to this individual, to the individual level. And this content seeks to answer the main questions, address the main issues. You'll see that this course is being launched in 3 languages: Spanish, English, and French. The same course, the same content that we have worked on first at PAHO, as well as with colleagues from the region of the Caribbean, health ministries, and health ministries of Latin America, in which we have put to the test this content to make sure it's clear, following WHO guidelines. So what do we want the users of this course to obtain? That they are capable of clearly defining cases of syphilis at different stages, for them to know what the different diagnostic tests are, which are the most effective clinical methods for diagnosis. This disease, congenital syphilis, usually is a asymptomatic disease. The alleged allergy to penicillin is a big barrier keeping women from receiving sufficient treatment. Now, there's a systematic review published by the Pan American Health Organization, in which it's shown that allergies to penicillin in childhood, adolescence, or as an adult, when there has been an allergy, the person can be desensitized, and from that point on, not have any problem with taking penicillin. Now, it's very important for us to identify and treat all sexual partners of the person being treated for syphilis. Non-treatment of the sexual partner means that the person can be reinfected. The mother can be reinfected at the time close to childbirth. We want these problems identified, which are easy to deal with, allergy to penicillin, treating sexual partners, and identification of diagnostics. This is what will make us feel more comfortable and secure, certain when we speak with pregnant women. This is a very operational course with 3 large components with content applied in practice to understand that the best care, as everyone has said here, following the guidelines of the WHO and PAHO to raise the knowledge of healthcare workers, respecting autonomy and the rights of people, the community and families. We can create a new generation without the stigma of these 4 diseases, but this course focuses on syphilis. Who are the recipients? These are target audience would be health workers, hospitals, healthcare centers that, as we've heard from these great examples, where testing and treatment take place. It can be the same place. That is the key element, one of the key elements for eliminating congenital syphilis. With 1 injection of penicillin, we can avoid stigmatization or death. Now, these are short modules that take from 30 to 45 minutes to read through. And of course, depending on how deep you want to go into the course, you could do this in a cursory, superficial way, or you can go to the reference documents and take a closer look at the content. The overall time commitment is 12 hours. These are 3 modules of content: the disease, diagnosis of congenital syphilis, and the 2 problems identified, which is desensitizing people from their allergies and also treating sex partners. Once you have passed the content, you will receive a certificate. As Gabriel has said, it's free to sign up. It's in multiple languages, and I'm going to share quickly with you just a short part of this welcoming video. Now, as you know, knowledge is power, and therefore, with this course, you'll be in a better position to diagnose cases of syphilis. First, we start by defining what syphilis is. We describe the different stages, we identify the different means for preventing and eliminating congenital syphilis. Syphilis is a sexually transmitted disease. Now, this is the mother-to-child transmission. Once a person is infected, reagents are produced. We address primitive means such as the use of condoms, some history on the discovery of penicillin, which has been used to treat syphilis for nearly 100 years. Now, latent syphilis is asymptomatic. Latent syphilis oftentimes is broken down into two phases. Congenital syphilis, this is a disease that can be prevented if the pregnant woman is tested at the early stages of her pregnancy and on a timely basis. Now, in this course, we're going to talk about the different methods for detecting syphilis, treatment options, prenatal care, and the role played by healthcare professionals to eliminate vertical transmission of syphilis. Now here, we'll give you an idea of how you're going to see the modules when you go into the campus. Once you have passed a module, the color changes. It becomes green with a check mark. Congenital syphilis, penicillin, allergies to penicillin, and then some clinical cases in which a narrative story is going to be told with multiple purposes. So a tree of decisions is going to open up as you are presented with this scenario. You have a positive test. And so this is a tree for decision making, which is going to lead to different outcomes. Just as in real life, we can eliminate the possibility of transmission of congenital syphilis or witness the death of a fetus because you didn't make the right decision, or a child is born with syphilis, stigmatized with attendant long-term health complications such as heart disease. And you can go back and rethink your choices. If your first choice wasn't accurate, wasn't right. And so you get the opportunity to think through your choice and to learn as you go. This is learning by solving problems. Ultimately, having seen these three clinical cases, we're going to talk about the key learning points. So the key issue here is to not forget the main concepts. This reinforces the main concepts. Theoretical, then interactive coursework, and then a conclusion or a summary. Now, the ultimate goal is for a baby to be born healthy. And now, if you get a score of 70% correct responses, then you pass. Now you can go back to the initial module, the second and third modules. If you have any doubts, questions, you can take the test again until you pass. The test can be administered as often as is necessary. There is no limit to the number of times you can take the test. This is what you're going to see when you are on the page. You see my name here as I'm signed in, the name of the course, and it will tell you, you have come this far. Are you ready for the final exam? Good luck. Let's get started. 30 questions. This just by way of example. You take the question a number of times. If you take the test rather a number of times, you'll see that the questions are going to be different each time. Questions change, the order of the questions change. You're going to be evaluated based on content with a different number or presentation of the tests each time you take it. Once you pass, after answering the multiple choice test, you will see a summary of your response, the questions that were not answered, and you can go back and start over and look anew at the answers you've given to the questions until you achieve a point in which this woman, the child, and the father are all healthy, and to avoid this case of vertical transmission of syphilis. This is a quick course and easy to get through. Here's the link to the course. You just click on this link and you'll be taken directly to the course. And even though we haven't yet launched it, there is a large number of people who are taking the course, who are passing. And once they've passed it, there's going to be a survey, a quality survey at the end. And so we ask you, please, to fill that survey out, telling us what you think could be better about the course in the spirit of helping us as far as the content, the time allotted for each module. And we've talked through every aspect of this test technically quite thoroughly. So if there's anything you think we could do better, we're all ears and eager to hear from you. I thank you for your participation, and I invite you to take part in this course, as my colleagues have said. Thank you.
Thank you very much, Rodolfo, for that quick presentation and overview of the e-training course. And I am very excited to hear of the number of persons that we already have participating in the course. And so we're expecting that this course, the participation will further increase after today. So this is where I will end my moderation for the launch of this course. And Rodolfo, I now turn over to you for you to moderate the section on the question and answers. Thank you very much.
Thank you very much, Sandra. And it is an honor for me to participate and launching with you, that we were working, a lot on this. Thank you. Vamos a tener unos poquitos minutos.
We just have a few minutes for a few questions. In the chat, I have captured a few questions that I'd like to turn back to the panel of colleagues who have participated. For those who are going to participate, I invite you to turn on your cameras to answer the questions. I think this one was actually already answered. It was posed by Guillermo and Eduardo, whether the HIV or syphilis treatment affects the fetus. So I think the answer has been given. If there is no such treatment during the pregnancy, that is when you have the vertical transmission. Perhaps Sandra and Leandro, we have a second question from Peter, which is whether the criteria for validation of these diseases is a global criteria, or whether PAHO has aligned itself with the criteria from 2018. So I'll give you the floor, Sandra and Leandro, to respond very quickly. Leandro is speaking. Perhaps I could start, and then Sandra can complement what I have to say if necessary. As regards this methodology, which the WHO published and continues to update, this is a methodology that was prepared in PAHO during the exercise of 2010 and then which was later validated in 2015 in Cuba. So this is the methodology that led to the publication of a global methodology that has some slight differences, but it is very much aligned with what PAHO did in terms of the validation processes. The indicators, some of the indicators for our region are more ambitious. For example, hepatitis B, vaccination globally, it's 90%. We want 90 above that. And we've also heard about this in the presentations, but they are very well aligned.
Thank you very much, Sandra. You want to add something to the answer?
No, I don't have anything else to add. Thank you very much.
Muchas gracias.
Thank you very much. Perfect. For Angelica, if you could turn on your camera, we have a question specifically for you from an anonymous participant. The question is, why did Brazil not initially include hepatitis B in the effort to eliminate vertical transmission? Rodolfo, I responded in the chat. It was just because of lack of information. People have local information, and it's different in some of the states and municipalities, but there is no national health information system. We are working to that end, and in 2023, we are planning to include this into this discussion. Perhaps in 2024, we can begin the process of certification, but it's just because of lack of data. We have low prevalence, but we do not have a way to prove this. Thank you very much, says Rodolfo, and a very clear answer as always, and a warm embrace to you. And then a question for the colleague from Peru. Andrea from Uruguay is asking, who funds the dual tests? Dr. Benitez, you have the floor. Could you, if you can hear me, could you please answer? Who funds the dual syphilis HIV test that the country is using? Who funds that? Leandro says, I believe we've lost Dr. Benitez. No, I do not see him here, says Dr. Mayorga. I think Dr. Benitez left the meeting. Then we have another question about whether erythromycin can prevent congenital syphilis. And I think that the answer is obviously no. You could see that in the cases that were presented in Jamaica, that pregnant women who were allergic to penicillin and then were treated with erythromycin still had cases of congenital syphilis. So I'd like to add another element here. And with that, I'll conclude the question section, Leandro. There are two definitions of congenital syphilis. One is the clinical definition, and the other is the epidemiological one. A woman who did not receive adequate treatment 30 days prior to giving birth and who did not receive penicillin, by definition, is a likely case of congenital syphilis. And for epidemiology, this is counted as a case of congenital syphilis, even if we do not have certification that it is clinically a case of congenital syphilis. And I see that Dr. Benitez is back with us. This slight difference could mean if we are not aware whether they were treated appropriately and on time, then that could be a case of congenital syphilis that we've lost. So it is epidemiologically counted as a case of congenital syphilis. Thank you very much for being with us, Dr. Benitez. We have a question from a colleague from Uruguay named Andrea. She's asking, who funds the dual test that you've been using in Peru, or how is this funded? Thank you very much for the question. The dual tests, just like the rapid test for HIV and for hepatitis B and C, are considered to be strategic public health inputs or supplies. Therefore, it is important for the country to invest in this in order to encourage access to these types of interventions. Therefore, they are procured by the state through centralized procurement that is more cost effective, and some is done through the PAHO Strategic Fund. And this is important because it allows us to deploy them nationally, even to different healthcare providers. In other words, we not only are working with people who use the public health system, but also people who do not have insurance and people who might have Social Security or other people who have private insurance. And so we address it as a strategic investment in public health. Thank you for the question. And Dr. Rodolfo Gomez adds, I add another part of this, another anonymous questioner had another question for Dr. Benitez. You and all of your innovations in Peru gave rise to lots of questions. Do you think that once you have this double test for HIV and syphilis, enables you to have greater diagnostic coverage? Yes, that's exactly what we were discussing with our technical team at the Ministry of Health a week ago. Our populations have a idiosyncrasy. The fewer jabs they get, the better. So we're trying to have tests that cover even 3 and 4 diseases, including hepatitis C, and this could be very beneficial in terms of improving access and also doing it more homogeneously throughout the various populations. In the case of hepatitis in the Amazon region of Peru, we have high incidence levels. In that scenario, it'd be very important to have tests that could screen not only for HIV and syphilis, but also for hepatitis. Excellent. Thank you. And I give you the floor, Leandro, for the closing remarks. Thank you very much. Thank you, Rodolfo. Before we go on to the closing, I also wanted to mention a point that Dr. Benitez mentioned at the end of his talk, and that is regarding LV, and this also has maternal mother-to-child transmission and something that could be prevented. And this is something that we're also working on. We're in discussions with the countries and within PAHO in order to include the elimination of HTLV. There are countries that are moving forward with this discussion, Brazil, Peru, and Chile. And we're also taking advantage of their experiences to move forward to address this. Last year, we also did a webinar specifically on ETMI and HTLI, so you can look for this, or actually, I mean, EMTCT. So we're also trying to define the impact goals and targets, but this is something else that we are working on. So I just did want to mention that point which Dr. Benitez made in his remarks. I think it's very important to have that discussion. Dr. Gomez, before we give the floor to Dr. Mayorga, I would just like to mention that the World Health Organization changed the number of recommendations and prenatal tests to be made last year. We have 4 in terms of quality control, but the number you're going to see that the number itself says nothing. You may have 4 prenatal tests, but not have done proper screening or treatment. So an indicator that is a proxy for quality, it's not a number, but the quality of antenatal control is the prevention of these, particularly syphilis and HIV. For us in the CLAP, interpreting antenatal quality healthcare is a significant reduction in vertical transition. A woman is screened, gets treated, and also is monitored at the time of birth. You may have 4, you might have 95% or higher coverage of the population with these 4 tests, but still not eliminate congenital syphilis. This indicator is a sensitive indicator regarding our work in the area of maternal and child health. My colleague Sandra Jones said we need to very much bring in the maternal and child health programs. That's our job. If we take care of women during pregnancy and help them to do this at a healthy point in their life and keep them healthy during pregnancy, that makes a significant contribution. We are the ones who can prevent these diseases that impact the health of our population. Thank you, and I now give the floor to Dr. Ruben Mayorga to close. I thought Leandro was the master of ceremonies. Go ahead, please. All right, thank you, Leandro. I'm very pleased with this webinar. We had some 300 people participating, and we've had several very important components of this webinar. Well, first is this extremely important course that is being launched to clarify some myths and misconceptions about management of syphilis, and this needs to be discussed. We also presented the progress made in eliminating vertical transmission of these 4 diseases, and we also see that we're making progress with some, but not with others. Unfortunately, syphilis is what has us the most concerned, and I think that Angelica's presentation does leave us quite concerned, but we are still hopeful that this is being addressed at the subnational level and in countries as large as Brazil, which is like many countries in one. So the approach is very important, the approach to vertical transmission, either at the municipal or state level. This is extremely important. So is the system that acknowledges efforts made and progress made by subnational entities in terms of elimination, trying to make sure that there are no setbacks. I think that that is extremely important as well. Next, I'd like to take up the words stated by several people. Suzanne Suruya said this at the beginning. We're talking about the elimination of vertical transmission of these infections is a characteristic that tells us the quality of the antenatal care. And I also want to go back to what Sandra Jones said, that it is extremely important for sexual and reproductive health programs, our antenatal care, whatever you call it, they should take a position about eliminating maternal to child transmission because it is part of their responsibility in antenatal care. We see that a certain number of antenatal checkups together with certain tests and treatments should be part of this. This is fundamental for eliminating maternal to child, mother to child transmission of these diseases. Next, I loved one of the concerns raised by the colleague from Jamaica relating certified treatment of syphilis, because we need to know that the person got the adequate treatment of syphilis and not that they got any treatment and that's not necessarily effective. In Peru, it was excellent to hear from Carlos, and this was also echoed by Angelica in terms of mentioning how important it is to address syphilis in key populations and in the general population. From Leandro's slides, we saw an increase in syphilis in general in the region and also amongst pregnant women, and an increase in congenital syphilis, which is a preventable tragedy. But at the same time, in some reports, up to 20% of men who have sex with men in the region are in clinical monitoring and they have syphilis. So we have to look at the quality of preventive care for HIV, should also include syphilis testing, and also determine whether this person has been treated or not, or whether they've been reinfected. That's important. If we don't do this, we will never put an end to syphilis transmission if you don't look at this infection in other populations. It's also important to note that this course is available for whoever wants to take it in the languages that we mentioned, and there's also an evaluation component which helps us make sure that the people who are taking the course have acquired the skills that they want and that they need. Next steps, we'll continue to work with the Regional Validation Committee to keep discussing these other modalities for certification of the elimination. For example, we've seen this in Brazil.
Con 12 millones de habitantes, pues es muy alentador
in a city like São Paulo with 12 million people, it's really encouraging to see that they are getting very close to the elimination of transmission of syphilis and the strides they've made with HIV. And their use of the different metals, gold, silver, bronze, to encourage cities to see how much progress they've made and to continue to make progress. Now, the other different diseases that are being proposed to include in the elimination of mother-to-child transmission, and something else we're very concerned about, which is the rise in the case of syphilis. A technical note is going to be issued on syphilis shortly, so for countries to start taking this as the crisis it really is. Leandro didn't tell you, but there is treatment for hepatitis B through the strategic fund of PAHO, affordable. Hepatitis C, rather, which is one of the diseases included in the Phil Cruz elimination program. Those are the final comments we have. I'm very happy that this topic garnered so much attention, and we are committed to continue working toward the elimination of mother-to-child transmission, and there will be more virtual and in-person meetings to delve deeper into some of the aspects that we touched on here. But I didn't want to conclude without highlighting these matters that I think to be so important for the work we've been doing. Leandro, you got the final word. Thank you very much. I think here we can conclude this webinar. I thank everyone for your time, your presentations. I thank the interpreters in 4 languages and all support staff. As Rodolfo said in the chat, these presentations will be shared with you, and the reports as well, the recordings, the videos in all the different languages. Thank you very much, and have a nice day.